Hello everybody. Today we are going to discuss heparin-induced thrombocytopenia. It is a question which was asked in DRNB Critical Care exam June 2022. So the question was to write a short note on heparin-induced thrombocytopenia and thromboelastography. Heparin-induced thrombocytopenia occurs in approximately 1 in 5,000 hospitalized patients with large variability among patient population. Patients who receive unfractionated heparin for 7 to 10 days, they are at highest risk, and incidence rate of 1 to 3% have been reported after cardiac surgery. So thromboembolic complication develop in approximately 50% of the patient with confirmed hit. Venous thrombosis of the large vessels of the lower limb and pulmonary embolism. These are the most frequent complications, followed by peripheral arterial thrombosis and then stroke. Myocardial infarction is uncommon. Thrombotic complication may also affect other vessels, including cerebral sinus and splanchnic vein. Heparin-induced thrombocytopenia type 1. HIT type 1, which is also known as heparin-associated thrombocytopenia. It is a non-immune mediated response to heparin therapy. HIT type 1 is more frequent than the type 2, and it occurs in 10 to 30% of patients after heparin treatment. Its typical presentation include mild thrombocytopenia, rarely below 1 lakh within first 2 days of therapy. It is self-limited direct effect of heparin and normalization of platelet count occurring spontaneously within discontinuation of therapy. So now heparin-induced thrombocytopenia type 2. HIT type 2 is the immune-mediated adverse effect and represents potentially catastrophic complication in which administration of heparin has to be discontinued as soon as possible at the time of clinical suspicion. It commonly develops after 5 to 10 days of treatment and manifests with the more severe thrombocytopenia or decrease in platelet count to less than 50% or of baseline. Here, severe thrombocytopenia means the platelet count is less than 1 lakh. So, HIT type 2 occurs with the frequency of 0.5 to 5% of patients treated with unfractionated heparin. Risk for HIT type 2 can be categorized into drug or host-related factor. Host-related risk factor include sex and age. According to Warkentin et al., there is higher predisposition, twice the risk for heat development in female in comparison with the male. In another study, it was shown that heat is rare among patients aged less than 40. So drug-related risk factor include the type of heparin use, that is unfractionated weight, whether we have used unfractionated weight heparin or low molecular weight heparin. And the next risk factor is the duration of the treatment. A study had shown that the patient receiving unfractionated weight heparin are 5 to 10 times more likely to develop HIT compared to patient receiving low molecular weight heparin, especially at therapeutic doses. The duration of treatment also has to be considered as a risk factor, as it's been shown that shorter duration of the exposure is associated with lower risk of the HIT. Now, pathophysiology, platelet factor 4. The responsible antigen for the development of the HIT is platelet factor 4. The platelet factor 4 has a various biological roles and it is implicated in several cellular processes such as coagulation, hematopoiesis, inflammation, and immune cell maturation. So platelet factor 4 is 7.8 kd, that is 70 amino acid in length, chemokine receptor produced from megakaryocyte and released from the platelet alpha granules. It is well known that platelet factor 4 neutralizes heparin action. This is achieved via high affinity binding on heparin due to positive charge of platelet factor 4 and the negative charge of the heparin. Thus, heparin molecule has no more ability to enhance the activity of antithrombotic. However, the problem does not occur due to heparin inactivation. Binding of platelet factor 4 to heparin molecule opens Pandora box. So this IgG antibody are formed against this platelet factor 4 and heparin complex, leading to creation of immunocomplex, which bind to the surface of the platelet monocyte and provoke their activation by cross-linking FC to a receptor. So platelet activation leads to the aggregation as well as to the generation of microparticle with procoagulant activity, where monocyte activation promotes the tissue factor expression, a glycoprotein that interact with the plasma factor 7 and 7. So tissue factor and the 7 complex enable the initiation of coagulation cascade via proteolytic activation of factor 9 and 10, leading to thrombin formation. Thrombocytopenia that occurs in the heat is moderately severe and main cause of clinical problem is elevated cause of thrombin. We can give rise to life-threatening thrombotic sequelae like pulmonary embolism, mesenteric ischemia, ischemic limb necrosis, acute myocardial infarction, and stroke. Now, the clinical presentation is the main clinical presentation of the HIT is thrombocytopenia with or without thrombosis. Despite the fact that these two features are key for diagnosis, there are many other clinical situations which can result in low platelet count as well as thrombotic events such as HIT type 1, massive pulmonary thrombosis, embolism, and DIC. So differential diagnosis can be done taking into account risk factor, time of onset of thrombocytopenia, clinical symptom, and life finding. Now, first is thrombocytopenia. Low platelet count is the cardinal manifestation of the HIT. The majority of the patient exhibit the thrombocytopenia with the decreasing platelet count more than 50% of the baseline or below 150,000. Thrombocytopenia can be the only manifestation of the disease, that is the isolated HIT, even though in this patient there is high risk for subsequent thrombosis. So thrombosis is the most severe complication of the HIT and it can affect any vascular bed. According to the study by the Varkan team, venous thrombosis occur more frequently than the arterial thrombosis. However, there are exceptions on this rule, and the prompt investigation in patients with presumed HIT is crucial in order to prevent more serious and life-threatening complications. Now, site for thrombosis. Venous thrombosis include deep vein thrombosis, pulmonary embolism, cerebral dural sinus thrombosis, and adrenal hemorrhagic infection. Arterial aortic occlusion, acute thrombotic stroke, myocardial infarction, thrombosis in upper limb, lower limb, mesenteric and renal and spinal arteries. Now, unusual sequelae, unusual clinical sequelae, including heparin-induced skin lesion and bilateral adrenal hemorrhages due to adrenal vein thrombosis, and it should be considered as a manifestation of the HIT syndrome. The importance of onset of symptom. The onset of symptom related to the heparin therapy is very crucial for the assessment of the diagnosis. As already mentioned, the pathogenesis of the HIT involves the formation of IgG antibody against the platelet factor 4 and the heparin complex, leading to the creation of immunocomplex, which will activate platelet and the monocyte. The presence of this anti-PF4 and heparin antibody is unusual in healthy patients. Warkentin and his colleague found that the average time for antibody detection in heparin new patient is about 4 days from start of therapy with thrombocytopenia and thrombosis occurring from day 5 to day 4. This is typical onset. In patients who had heparin treatment during the last 100 days, the onset is rapid with sharp decrease in platelet count within 24 hours. On the other hand, HIT can occur days and weeks after heparin cessation. This situation is described as delayed onset HIT. Now the diagnosis is thrombocytopenia is rather common manifestation in the patient treated with the heparin. But as mentioned before, the treatment with the heparin does not always lead to HIT. So there is increased need for accurate tool to distinguish patient at risk of developing the syndrome for patient who have thrombocytopenia due to other causes. There are several scoring systems which can help physicians to predict the likelihood of HIT. The most widely used is 4T protest scoring system. The 4T system is used to estimate the likelihood of HIT based on the available clinical features of the patient receiving heparin treatment. So each factor has 0 to 2 scale with the maximum value of 4T score being 8. So 4T points are thrombocytopenia, onset of platelet count fall, thrombosis, and other causes of thrombocytopenia. So this thrombocytopenia, the 2 points are allotted if there are more than 50% or and the player drop in the platelet count. Then 1 point is allotted if this fall is between 30% to 50%, and 0 point if the fall in the platelet count is less than 30%. Then onset of the platelet count fall, the 2 points are given if the onset is between 5 to 10 days. And 1 point is given if it is a consistent with the day 5 to 10. 0 point is given if the platelet count fall less than 4 days. Then thrombosis and the other sequelae. 2 points are given if there is no thrombosis, that is skin necrosis. 1 point is given if there is progressive or the recurrent thrombosis. 0 point is given if there is no thrombosis. Then other causes of thrombocytopenia, if a none is if there is no apparent cause, then 2 point. If there is possible cause of thrombocytopenia, 1 point. Then if there is definite cause, then 0 point. The 4T scoring system is used to make the presumptive diagnosis until lab results are available. It was named after four factors taken under consideration. That is thrombocytopenia, time or onset of thrombocytopenia, thrombosis, and other possible causes of thrombocytopenia. The patient based on their score are categorized into three different probability subgroups. The low risk group has a score of 0 to 3 with the low probability of developing antibody mediated HIT. Intermediate risk score with a score of 4 to 7. And patient has 40 score of 6 to 8 is high risk group. Risk of developing HIT in this group exceeds 80%. While it is clear whether the low or high risk group are in the danger of developing HIT or not, the intermediate risk group is most uncertain. For patient in this group, the lab detection of autoantibodies will be the most crucial factor that will determine the therapeutic approach that physician will follow. However, physicians have to take into consideration the possible delay in the lab results. The interesting point is that the patient with no clinical evidence of thrombosis who fulfill other clinical characteristic of the HIT can have 40 score of 6 and thus justify the use of alternative antibiotics. 40 scoring system have the increased negative predictive value of 99% for low risk group, while the intermediate and high risk group have positive predictive value of 14% and 64% respectively. So physicians have to take into consideration that incorrect or missing information of the 4T factor can lead to false score and consequently bad decision making and incorrect therapeutic approach in patient with the HIT. Although informative and useful in clinical practice, the 4T scoring system has limitation in the intensive care unit patient and in the management of the patient undergoing cardiac surgery. So in patients who are categorized as having intermediate or high risk for HIT, based on their score, heparin should be discontinued and alternative anticoagulation medication has to be started. HIT antibodies have the high affinity for low molecular weight heparin, and for this reason, the low molecular weight heparin has to be excluded from the available therapeutic option for this patient. The initial about lab investigation, the initial management has to be according to the probability of the HIT in order to prevent the major complication and avoid the increased risk of mortality. taking into account that lab result may not be available. So lab investigation has complementary role to the diagnosis and should be performed only in patient with the clinical suspicion of the heat. That is, the patient with the intermediate and the high probability score. There are immunoassay and the functional assays for the detection of the heat antibody. Immunoassays are performed using enzyme-linked immunosorbent assay technique. The patient's serum is added to the microvalve coated with platelet factor 4 and polyvinyl sulfonate complex. In the presence of antibodies against this complex, the binding will occur. Second label antibody is used in order to confirm binding and by extension presence of heat antibody. Immunoassay on one hand had the advantage of sensitivity, but on the other hand lacked specificity. And for this reason, several different technical approaches have been developed for their improvement. Functional assays include serotonin release assay and heparin-induced platelet activation. So in this assay, the donor platelet are incubated with heparin and patient plasma in order to measure heat antibody-induced platelet activation. Functional assay have the high sensitivity of more than 95%, but exhibit wide range in the sensitivity from 60% to 100%. Now about management. Two pillars of heat management are immediate heparin cessation and initiation of alternative anticoagulation treatment. Patients who are categorized as immediate and high risk based on their 40 score are discontinued for the heparin. And heparin administration should be avoided from any source for this reason. Heparin-coated catheter should be removed. Cessation of unfractionated heparin is not sufficient to prevent thrombotic event, and alternative anticoagulation medication should be provided, with exception of both low molecular weight and warfarin, which can induce thrombin generation and increase the risk of thrombosis. Alternative anticoagulation therapy involve direct thrombin inhibitors such as ergotropan, bivalirudin, factor Xa inhibitors such as danaparanoid and fondaparinux. Then regarding direct thrombin inhibitor, ergotropan is the synthetic direct thrombin inhibitor that reversibly bind to both free and the clot-bound thrombin. It is approved by the Food and the Drug Administration in the United States for the treatment of the heat as well as for anticoagulation in patient undergoing PCI when heparin is contraindicated. Its administration is via continuous IV infusion at the dose of 2 microgram per kg per minute, and steady state is achieved within 1 to 3 hours. Treatment with ergotropan is monitored by measuring activated partial thromboplastin time, that is target range of 1.5 to 3 the baseline activated partial thromboplastin time. Bivalirudin is also synthetic hirudin analog, and it is a direct thrombin inhibitor that binds to both free and clot-bound thrombin. It is used during cardiac surgery in patients with active or recent history of heat and as a possible alternative for treatment of the heat. In contrast to ergotropan, which exhibit hepatobiliary clearance, bivalirudin clearance is achieved renally and by enzymatically degradation. The administration is via continuous IV infusion at a dose of 0.15 mg per kg per hour. Factor Xa inhibitor. Danaparoid is the non-heparin low molecular weight sulfated glycosamine glycan that exhibits long-acting antithrombin dependent anti-10A activity. It has been approved for the treatment of the heat and does not cross the placenta. Danaparoid is given intravenously with the initial bolus dose according to the patient's weight. So treatment with the danaparoid is monitored by measuring anti-10A activity. Fondaparinux is the synthetic analog of the antithrombin binding pentasaccharide sequence, a synthetic antithrombin dependent factor Xa inhibitor. Despite the fact that fondaparinux has not been approved for heat treatment, and it has several advantages over direct thrombin inhibitor, such as once daily subcutaneous administration and no requirement for routine anti-10A monitoring. Now transition to the vitamin K antagonist. Heparin-induced thrombocytopenia is a recognized risk factor for subsequent venous thromboembolism. Thus, anticoagulation treatment has to be continued for 6 weeks in patient with isolated heat and for 3 months in patient with thrombotic sequelae. Early administration of the warfarin should be avoided due to risk of warfarin-induced skin necrosis, venous gangrene, and should be slowly introduced only when the patient's platelets have returned to normal level. Shifting from direct thrombin inhibitor, especially argatroban, to vitamin K antagonists remain challenge for clinicians. There should be overlapping period of 5 days between vitamin K antagonist and chosen parenteral anticoagulation. And it is well known that argatroban leads to profound increase in INR, making the transition difficult. Now about thromboelastography. It is the first measurement of note is the reaction time. This is the time interval from the start of the test to the initial detection of the clot. This value is roughly equivalent to the prothrombin time that provides the measurement of extrinsic clotting factor and APTT that provides the measurement of intrinsic clotting factor in standard coagulation assay. So, the R time provides information about clotting factor deficiencies or possible heparin therapy. So the major advantage of TEG over APTT is the ability to add reagent heparinase to monitor patient currently receiving heparin therapy for the other possible clotting deficiencies. So the clot strength is measured by two variables in the TEG. So that is K value, which represents the clot kinetics and measure the interval between the R time and the time when clot reaches 20 minutes. Alpha angle is the another measurement of the clot kinetic and measures the line tangent to the slope of the curve during clot formation. Both this parameter depends mostly on the fibrinogen level. This can help identify states of hyper and hypocoagulopathies. So maximum amplitude is the measurement of the maximum clot strength and provides the information on both fibrinogen and the platelet function. So current coagulation profiles include platelet count, but generally do not take into account platelet function. Disruption in the endothelium causes exposure of collagen and one Wilbrand factor. Platelet then adhere to this and release the substance that cause platelet aggregation. Fibrinogen then bind to glycoprotein 2b3a receptor, causing further platelet aggregation and formation of platelet plug. So platelet function is the integral part of the clot formation during surgery, and alteration in the function can disrupt the ultimate formation of the clot. The last measure of TEG parameter is lysis 30, which measures the percentage of clot lysis 30 minutes after mean amplitude is achieved. This measurement is the most useful for patients undergoing thrombolytic drug therapy or during more advanced stage of DIC. This can be observed by rapid curve convergence. Thromboelastographic curve represents the coagulation status at the time of blood draw. So during the changes in the coagulation, such as during active hemorrhage or period of massive transfusion, this status can change rapidly. So thromboelastography offers the ability to monitor multiple consequent samples all at one time. So this is the pictorial representation of normal thromboelastography tracing. So initial is R time. The clot strength is assessed by K and alpha angle. Mean amplitude will tell us about the platelet, and then LY angle is the will tell us about the status of the lysis. So this is the interpretation of TEG analysis. So as shown in the diagram 1, the normal hemostasis normal TEG will be is demonstrated. If this is the case, then no need to administer any platelet count. Then in second diagram, the R value is high. The so if R value is high, then we should add fresh frozen plasma if indicated. Then in the third diagram, the this K and the alpha angle is low, and the mean amplitude is also low. So we can administer cryoprecipitate. In fourth diagram, so there are the low platelet count. So we need to administer platelet here. Then in fifth diagram, it represents the low mean amplitude. So we need to plus. So we need to administer antifibrinolytic or tranexamic acid as indicated. So, and because it also indicates the fibrinolysis. Then next diagram is showing secondary fibrinolysis in which R angle is very low, K alpha angles are high, and the maximum platelet count is very high. So this is the picture that we have seen in the DIC. So we need to treat the cause of DIC. Then the last diagram is showing K alpha angle is high, maximum amplitude is high. So we need to administer anticoagulant. Now thrombography guided transfusion management. Impaired homeostasis and coagulopathies are known to cause serious conditions associated with morbidity and the mortality during major surgery. So poorly guided transfusion therapy during massive transfusion protocol can cause or worsen existing coagulopathy. In addition to worsening coagulopathy, blood transfusion are associated with transfusion reaction, that is transfusion-related acute lung injury and transfusion-related immunodilution, among many other issues. Multiple studies have found that using transfusion algorithm based on TEG tracing decreases the amount of the blood product transfer. This is not only decrease the risk associated with blood transfusion, but also decrease the total treatment cost and strain on the blood bank resources. Alteration in the R time represents the alteration in the hemostatic clotting factor. If this value is elevated, it can signify the deficiency in clotting factor, hemodilution, or increased endogenous heparin production. If excessive heparin may be present if R time is prolonged in normal sample, but may be normal in a sample with heparins. Prolonged R time in sample with heparinase may indicate hemodilution, clotting factor deficiencies, and this value could indicate a need for transfusion of fresh frozen plasma. On the other hand, shortened R time can indicate hypercoagulopathy, warranting the use of anticoagulants. Alteration in the rate of clot growth, as evidenced by changes in the K value and alpha angle, shows the clot growth kinetics. A low value indicate deficiency in the fibrinogen and may reveal a need for cryoprecipitation. Similarly to the R time, high value may represent a hypercoagulable state in which anticoagulant may be applicable. Then MA value, which is the ultimate strength of the clot caused by the fibrin and platelet bonding. So low MA value is indicated by the low clot strength, which can be caused by decreased fibrinogen level, low platelet count, and decreased platelet function. So paired with the low K value, this could be the sign of need for cryoprecipitation. This parameter becomes most important when paired with the platelet count. Administration of the platelet may be avoided with the low platelet count, but normal platelet function as indicated by normal MA value. Conservatively, the treatment with the platelet may be indicated for patients with the low MA value or low platelet function and normal platelet count. High MA value may indicate the need for anticoagulant. Now about the clinical application. We can make use of TEG in the cardiopulmonary bypass system. Extracorporeal circulation during cardiopulmonary bypass in surgical patient has long been known to cause coagulation disturbances. So cardiopulmonary bypass disrupt the hemostatic system in number of ways, including hemodilution of procoagulant and platelet, a reduction in coagulation factor due to interaction of the blood with surface of bypass circuit, the use of heparin and altered temperature. Hemodilution of the clotting component occurs mainly due to large amount of crystalloid and colloid solution used to prime bypass circuit. Exposure of the heparinized circulating blood to the bypass circuit as well as surgical wound activate both intrinsic and the extrinsic clotting cascade, triggering the prothrombotic reaction. Heparin is administered in the large doses, but it cannot prevent this thrombin formation. So heparin can only reduce the thrombin after it has already been produced. This constant formation of thrombin leads to what is called as consumptive coagulopathy due to exhaustion of the clotting factor. Hypothermia is known to cause multiple coagulation abnormalities, leading to increased bleeding. So low body temperature blocks the thromboxane synthesis, which results into the decreased platelet aggregation. Traditionally, coagulation is monitored using ACT throughout the cardiopulmonary bypass surgery. So research has demonstrated ACT to be less accurate than TEG or APTT in this setting. Activated clotting time has many disadvantages, including inability to monitor true heparin level, as well as impact of temperature and hemodilution on the ACT level. The manner in which TEG is monitored is believed to be analogous to in vivo coagulation because it takes into account the temperature as well as impact of platelet on hemostasis. In addition, the TEG is superior to ACT in this setting because of the unique ability to isolate heparin in the TEG sample using heparin X. This allows the practitioner to monitor underlying coagulation issue, not mistaking bleeding disorder for heparin therapy. The use of TEG-guided algorithm during cardiac surgery has been shown to reduce the number of blood product transfused as well as number of the patient requiring transfusion during cardiac surgery. Now about liver surgery. The liver is major source for production of clotting factor. So patients with the chronic liver disease have defect in coagulation, making them population requiring targeted transfusion therapy. So generally it is understood that patients with the chronic liver disease have lack of clotting factor and therefore hypercoagulability. However, these patients can also exhibit systemic hypercoagulability because of concurrent lack of natural anticoagulant. Because of their clotting issues, patients with chronic liver disease require a quick assessment of coagulation abnormality and targeted use of blood product for management of this abnormality. Thromboelastography provides the more complete assessment of coagulation abnormality and has been shown to reduce the amount of blood product utilized in this patient population. Although it has not been demonstrated that this decrease in blood product utilization has impact on long-term morbidity and mortality. So thromboelastography guided transfusion therapy has demonstrated applicability not only to liver surgery but also to chronic liver disease, liver cancer and pancreatic cancer patient population. About trauma surgery, coagulopathy resulting from traumatic injury is a common occurrence requiring rapid intervention. Coagulopathies are associated with high rate of mortality in trauma patients. This is especially true within the first 24 hours after trauma incident. There are multiple mechanisms that contribute to coagulopathies observed in the trauma. The first resuscitative effort after trauma are generally crystalloid and colloid that do not contain clotting factor, leading to hemodilution coagulopathy. Another cause of traumatic coagulopathy is rapid administration of clotting factor, similar to consumption of clotting factors observed in patients undergoing cardiopulmonary bypass. An additional method of coagulopathy involves the activation of protein C due to hypoperfusion from hemorrhage during traumatic surgery. So activated protein C affects the coagulation in two ways. This protein C inhibits the clotting factor 5 and 8, decreasing the total thrombin formation. It also decreases the inhibition of tissue plasminogen activator, which causes plasminogen to convert into plasmin faster, leading to fibrinolysis. So this combination rapidly leads to coagulopathy and fibrinolysis following trauma. So traditional coagulation tests are of limited value in this population of patients because of the inability to detect clot strength and the length of time required to obtain result. For patients with the trauma, TEG offers benefit because of the rapid return of result, the power to measure clot strength, and the ability to monitor hyperfibrinolysis, commonly found in this population. A systematic review of the literature found that targeted use of the blood product and clotting factors used by TEG reduce the overall incidence of morbidity and mortality in this population of the patient. Then obstetrics. Obstetric is the another patient population for whom TEG can improve monitoring of the coagulation status. Female exhibits the many coagulopathies during pregnancy. These range from the normal physiological changes causing hypercoagulable state to coagulopathy exhibiting during hemolysis, elevated liver enzyme, and low platelets count. So, coagulation status of this patient is particularly important for anesthetists because of risk of epidural hematoma with neuroaxial blockage. Although the incidence of epidural hematoma in genetic obstetric population is 1 in 1,68,000 and is relatively low, several case studies and cohort studies suggest the high incidence of coagulopathic patients. Traditionally, the major factor determining the safety of neuroaxial anesthesia for laboring parturient has been the platelet count. The platelet count alone is rarely responsible for marked changes in coagulation in this population. So, thromboelastography is being used successfully to predict morbidity following neuroaxial anesthesia. A recent study found that parturients with the low platelet count but normal take could safely receive neuroaxial anesthetic. Additionally, take more patient with hypercoagulopathies and can help provide dosing of low molecular weight heparin in this patient. Thank you, guys.